Recording in progress.
All right. So for this Eugene India Colposcopy MDT today, we are presenting from the Department of Gynae Oncology, King George's Medical University, myself and my Senior Resident Fellow, Dr. Valina Narang. The experts for the program are from pathology. It is Dr. Madhu Kumar from KGMU Lucknow. She is a professor in Department of Pathology. And we have the clinical experts, Dr. Pratibha Singh from AIMS Jodhpur and Dr. Dipanvita Banerjee from CNCI Kolkata. So we'll be sharing 3 cases, and I hope that the discussion will be very fruitful for all the participants. So Valina, you can start off with the first case.
Yes, ma'am. Good evening, everyone. So the first case for today's evening is Mrs. X. She's 38 years old and she has complaint of pain lower abdomen. And on examination, there was no other abnormality detected and routine LBC was done. So we have Dr. Madhu with us and she will tell us something about LBC first.
Good evening, all of you. Thank you, Nisha ma'am. And before starting the liquid-based cytology, I want to tell you some basic points related to the liquid-based cytology as well as the reporting classification of Bethesda system. Liquid-based cytology, basically this is an automated smear preparation and pap smear staining technique. And this is the screening test for the cervicovaginal cytopathology as well as non-gynec samples. We use the LBCs technique. And what is the Bethesda system? Bethesda system is the international uniform standards reporting system for the diagnosis of for the reporting of the cervical cytopathology across the globe. And these cervical reports should give the clinical appropriate and relevant information to the treating surgeon for the management of the patient. Next slide. And in this smear, you can see these are the, there is no pointer, there is a pointer. As you all know, the cervical
you can just go ahead,
cervix
Dr.
has a ectocervix and endocervix. The ectocervix is lined by the squamous epithelium and endocervix is lined by the endocervical columnar epithelium. In the first picture, you can see the 2 colors, pink and blue. Because there is no pointer, so I have some problem. So just I want to tell you the colors only. The pink color is a superficial squamous cell, shows the dark small pycnotic nucleus, and this is a polygonal in shape. And blue cell is a intermediate cell with the central nucleus, and the size of nucleus is slightly larger than the superficial squamous cells. In the next picture, you can see the clusters of the endocervical cells. And the third picture shows the intermediate cells. Intermediate cell, basically this is the reference cell for the diagnosis of whether this is the ascus or L cell. So if the size of nucleus is 2.5 to 3, less than 3 times the size of the intermediate cell, then we signed out as a ascus. And if the size of cell is more than 3 times the size of the intermediate cell, then we called as a L cell associated with the coelocytic changes also. And what is the Bethesda system? What is the need of Bethesda system? Is this is for the clinical or diagnostic surgical management of the patient. And Bethesda system includes the specimen types, whether this is the conventional smear or liquid-based cytology smear, specimen adequacy, the smear is satisfactory or unsatisfactory. If we write down unsatisfactory, then write a cause why this is unsatisfactory smear. And general categorization include the negative for the intraepithelial lesion or malignancy. Negative for intraepithelial lesions includes the non-neoplastic cellular variation as well as reactive cellular changes associated with the inflammation, radiation, IUD changes, and glandular cell status also write on the reports. And the various organisms like the Trichomonas vaginalis, fungal Candida, and Actinomyces, Leptothrix, herpes simplex, cytomegalovirus, and endometrial cell is important to write in a woman more than 45 year of the age, and epithelial abnormality like squamous cells and glandular cells. Squamous cells like atypical squamous cells, LCL, HCL, and squamous cell carcinoma. Glandular cell, atypical endocervical cells favors the neoplastic or non-neoplastic endocervical adenocarcinoma in situ and adenocarcinomas, whether endocervical or endometer. Now come to on the R case. This is the ascus. Ascus, atypical squamous cells with undetermined significance. The pink color cell is the superficial squamous cell, and the size of cell is just below the pink cell. This is the normal intermediate cell, and in the left side you can see a group of cells. The nuclear size is enlarged, but there is no nuclear abnormality, there is no nuclear pleomorphism, and this is there is no hyperchromasia. So this case we write as a ascus. And next slide, next.
Yes.
So this is the case of ascus.
So what should be the
The
next
next.
step in this case? We would like to discuss with our clinical experts.
So, Pratibha or Dipanvita, any one of you can take this.
Hello. Yes. Yes.
Yeah.
Can I go ahead?
Yeah, please.
So, since we see a very benign looking cells over here, and as the pathologist has rightly given us the diagnosis of ascus, we all know it could be normal, a part of the normal reparative process, sometimes after specifically after some kind of infection. So, these kind of cells, these kind of reports, when we know these things, and specifically if there are no other high risk factors, we know that these group of women are can be kept under observation. So what we do here is generally we ask the women to come back after 6 months to 1 year. Ideally should be within 6 months to 1 year, though we do take consideration of the women's choices as well as the risk factor, whether she is HIV positive or not. And if she is having no other risk factors, then we can wait for 1 year, do a repeat smear, and then accordingly plan what needs to be done further, depending on whether the repeat smear is again ascus or it is inflammatory. But practically speaking, what we see in our day-to-day practice is that the moment we'll get to know that this smear has showing some kind of abnormality, though however minor, we can also have an option of offering these women a choice of colposcopy, or if the facilities are available, maybe we can even go for HPV testing. And many centers in India, including ours as well, we are offering HPV testing in a few selected group of women because HPV test becomes a little costly. So we are not offering it to everyone. So,
So,
definitely we have a choice that we can either straight away go for colposcopy or we can go ahead with a HPV. And if the high risk HPV is positive, then the management entirely changes. We need to go ahead with the colposcopy and this thing. And if the women is ready to come to us to follow up, I think the best way would be to wait for another 6 months to 1 year, do a repeat smear, and then decide what needs to be done further.
so Dipanvita, would you like to add the importance of HPV
Yes, so
testing in
HPV
ascus?
is ASCUS is the cytology report where HPV test does have an indication. So HPV DNA testing can be used as a reflex test, so that like we know for the ASCH straight away send for colposcopy. For ASC benign
Basically,
lesions,
LCL and
NILM,
above. Basically,
LCL,
LCL and above, we
yeah,
can go for colpo directly. But for
colposcopy.
this,
But for
yeah,
ASCUS is the cytology where there is a role of HPV. If the HPV is positive, you send her for colposcopy. If
definitely.
HPV is negative, you can offer her that you can be undergo for a follow-up. It's a yearly follow-up
Yeah.
by doing a cytology
So,
again.
yeah, but in this case, I think the colposcopy has been done. So we'll just discuss that.
Mm.
So what are the other indications like for colposcopy if like ascus and then HPV negative we can offer? What are the common indications for going for colposcopy, just
So,
for
like,
the audience,
yeah,
anyone.
so colposcopy colposcopy is a facility which we can utilize. Like for indication, any screen test positive is an indication,
Yes.
whether it is
Yeah.
VIA test or a HPV DNA test or a cytology abnormal site pap smear is an indication for colposcopy. Apart from that, colposcopy is used for treatment purpose when we are performing a LEDS or a loop, a leap procedure.
Right.
Then any suspicious looking cervix, on clinical examination,
Malina,
first
you can
if you
just
have the
show.
facility.
Yeah, just
So you can very well go ahead and do this colposcopy, because it gives us advantage of having a magnified view of the cervix. So wherever any doubt, any persistent, like most of the things are covered, like abdominal screen test positive, any
that is the
kind of
main one,
suspicious
and
looking
yeah,
cervix.
right.
So DS
So
exposure, I don't know whether we are getting it or not.
we are not getting
now.
nowadays.
Yeah,
It's just in the list, so I
list,
mentioned
so
here. Yeah,
yeah, and
okay.
for the therapy, for the LEDS purpose, we can use colposcopy
We'll use it.
performing.
Yes.
Yeah.
Management purpose. Next,
Yeah.
please.
So these are the colposcopy findings after normal saline and after green filter. So can we have someone describe the findings, what they can see here?
Any of you can take up Dipanvita or
Dr. Pratibha, would you like to comment?
that's okay. Dipanvita, go
Yeah,
ahead.
so for colposcopy finding, it would be like we do follow when interpretation of colposcopy finding, we do follow the IFCPC 2011 colposcopy terminology. That
Yes.
so documentation, once you are interpreting the colposcopy finding, you have to document it also. So first thing is whether the cervix is the finding is adequate or not, that the whole cervix is visible completely or not. So colposcopy is adequate, squamocolumnar junction is fully visible, the transformation zone is type 1, 2 or 3. Here I can see it's type 1. Then any vessel abnormality is there or not, whether it is present, absent, or if it is present, then the nature of the vessels needs to be documented. Then after you apply Lugol iodine, go ahead and see that what is the staining pattern, whether it is patchy stained or it's a fully stained, or there is definitely yellow
you
color.
can
It's a
tell.
canary yellow, we can say. So with this finding, the colpo interpretation should be like minor grade abnormalities. If we go by the IFCPC colpo terminology, it's whether it is normal finding or a minor grade abnormalities, major grade abnormalities, or suspicious of cancer. So here, as you rightly mentioned, it is a thin acetowhite epithelium, irregular geographic border, and it's occupying all the quadrants. Like in most
circumoral kind of, just around the,
circumferentially occupying all the quadrants. So looking at this, her SWET score would be 5.
So let's have the description of the SWET score first. What are the things we see, and then you can score for this patient.
So for the SWET score, we do see that aceto uptake, whether it is thin or distinct or there is none. Then the margin of if there is any aceto uptake here, in this case it is thin. Then the margins, whether those are there is no lesion. So all the 0 parameters are mostly for the normal finding, except for the vessels. And when the margins are definitely here sharp but irregular and jagged. So these are the findings which suggest that the patient might have a HPV infection. Usually the HPV infected cervixes, the lesions are more like this irregular jagged margin. For vessels, there are no vessels seen. So absent. Lesion size is of course big, and it is 2, occupying 3 or 4, and the iodine uptake is 1. So it is 1, 2, 3, 4, 6. 5, 6.
Right.
Because of the size of the lesion, it has 6. It has 1 to 6.
True. So how will you manage this case now?
So
these are the
for
various
her,
options written. Put it up. Yeah, put up that.
so
image.
if we go by, now comes the role of the single visit approach. if the woman comes and you have to see and counsel the women that whether she needs she can come again, or
Right.
this you have to also assess that whether this will be like she might get lost to follow up.
Yes.
So here the wisdom of sensing that thing in the patient who will be compliant or not comes. So with CIS more than 5, usually the recommendation is you have to take a biopsy because the CIN2 and above, the sensitivity is high in detection of high grade lesion. So biopsy I would definitely would like to do for her. And as I mentioned, a single visit approach, if we go by that, the screen and treat that whether the
Yeah.
patient will be able to come or not, you can treat her in that sitting as well. So there is
Yes.
no hard and fast rule for that. You have to follow the book every
Yeah.
time. You have all these options are there. As and when required, you apply.
Yeah, so like if you are taking a biopsy, you have the facility still simultaneously after taking the biopsy, you can treat it also by the thermoablation
Yes,
or the cryo,
yes,
and or you can send it and then according to the report you may do if you think she will be coming back and
coming back
she
to.
is a
So
good
that
for
is
yeah.
the
Yeah,
the
right.
judgment you have to do then and there, that
Absolutely.
whether the patient will be able to come
Yes.
again or you
Yeah,
will
so
treat her
maybe
then
we have
and there.
got the slides of the biopsy that was done from the two lips of the cervix, since it was all around the os. So maybe Dr. Madhu can explain these
Yes.
slides, what she
Yes.
saw.
As you can see, this is the you can
Is
see
this
this is the squamous epithelium, and this is the sub underlying zone. And before describing whether this is the sin 1 or 2, I want to explain some. Next slide. I want to explain some terminology related to the cervical intraepithelial neoplasia. In the previous year or in the old times, the dysplasia we classifies as the mild, moderate, severe carcinoma in situ. After that, the invasive carcinoma. Now, what is the dysplasia? Dysplasia is the abnormal enlargement or proliferation of the abnormal cells. It could be in the form of nuclear irregularities, hyperchromasia, and increased nucleocytoplasmic ratio. And after that, there is the terminology of cervical intraepithelial neoplasia. It classified as a CIN 1, 2, and 3. And after that, there is some modification in the CIN. It is classified as a low grade and high grade. Low grade CIN equivalent to the mild dysplasia, and high grade CIN equivalent to the CIN 2 or 3, means moderate or severe dysplasia. According to the Bethesda classification, the squamous intraepithelial lesion classify as in a two-tier system, means low grade or high grade. Low grade squamous intraepithelial lesion equivalent to the sin 1, and high grade squamous intraepithelial lesion and classify as a like previously classify as in 1, 2, and 3, but now only two-tier system: low grade dysplasia or low grade cell and high grade cell. And
so yeah.
this is the histopathological smears of this case. In the first picture, this is the normal epithelium. This is the normal epithelium, and you can see here.
Valina, stick to that slide only.
In the squamous epithelium, the major squamous epithelium, intermediate cells, and the parabasal and basal cells. Superficial cell is the mature squamous cells, and basal cell is the immature cells. So, according to the low grade or high grade dysplasia, the squamous epithelium as a imaginary line draw of 1/3, 2/3, and the full thickness of the. If the dysplasia or the atypical changes, dysplastic changes involved or confined to the lower 1/3, then called as a SIN 1. Or if confined to the more than 1/3 but less than 2/3, then moderate dysplasia or high grade SIL. And if entire thickness, this means there is the full thickness dysplasia or carcinoma in situ. Next. So we come to our case. In this picture, you can see there is the dark blue color cells, hyperchromatic cells, with occupy the more than 1/3 but less than 2/3 of the area, as well as there is the coilocytic changes. There is these coilocytic changes are showing these coilocytic changes are showing some atypical nuclear atypia. So we report this case as a CIN1 or 2. For the differentiation of whether this is CIN1 or 2, for the differentiation whether this is the low grade or high grade lesion, so P16 and Ki67 plays very important role for the differentiation whether this is the low grade or high grade. As you know, the P16 is a protein that is strongly linked with the HPV infection, and the interpretation of P16 is very important. In the SIN1 or 2, the P16 protein is a very weak positive or patchy positive. If this is the patchy or weak, then this is reported as a negative staining. And for the P16 positivity or overexpression of the P16, it shows the block positivity. Block positivity means the both nuclear and cytoplasmic positivity. It stains the brown color. The entire epithelium, it can be brown in color. So this is there is the overexpression of the P16. So in squamous epithelium, block positivity leads to the involve the basal and parabasal cells. So we can differentiate the whether this is the low grade or high grade dysplasia. And Ki67 is a cell proliferation marker, and in the normal normally this is the squamous epithelium. This is the normal. Only stains the basal layer of the epithelium. In low grade cell, it stains the 1/3, and in the SIN2, it stains the more than 1/3 but less than 2/3. And in the full thickness or in the dysplasia or CIN3, it stains the entire epithelium. So we differentiate whether this is the low grade or high grade dysplasia.
So in this case, if we do not have the availability of P16 and Ki67, then how will we proceed in the absence of that?
So
So
follow-up
basically,
is a good. Yeah, ma'am, please.
no, I was just
Okay, hi, Dr. Nisha.
you have understood the question. Basically, if we have the facility, then they clearly write, adding that and telling us, and then it becomes easier. But if there's a report like this, and 1/2, how do you proceed? How will you manage? So still we can go for observation, or we should do a thermo and cryo. I
So
think it will again
with her
depend on.
colposcopy finding a low-grade lesion along with this biopsy report, so I would like to go for observation for her.
Okay, Dr. Pratibha,
So
same
now
for you?
again that
Same here.
yeah.
Because if we look at all the clinical parameters till now, we have a
Yeah.
report of ASCUS, then we have a colposcopy report which is showing a low grade score, and here again, if there is a doubt of whether CIN1 is there or CIN2 is there, giving her a benefit of doubt, I would still think that if the patient is ready to come to me for follow-up regularly, then definitely I'd like to keep her under observation. However, if she is not ready to come for follow-up, then probably I'll think in the other way around that probably I'll go ahead with the ablative treatment for her.
All right. Okay. So what should be the
No,
follow-up
for
with the phone?
ablation is also, I don't know, ablation, whether she will be suitable for ablation or not, that will be a question.
the
Cryo
Like,
may
lesion
be
was
a
quite
little
big.
better for her because it is all around, and maybe if it can, the tip can cover and
yeah,
this
thermal
thing.
ablation you're talking about.
But
Thermal.
The cryo or
so
thermal ablation. So,
yeah, okay.
but
So I think
definitely.
she's on observation. So because
Hmm.
we are all coming to this thing that she seems to be a patient who is coming, getting things as advised and all. So she can be kept on follow up. So what
Hmm.
will be your follow up protocol?
So HPV is ASCUS with HPV negative her repeat cytology after a year.
Right.
That would be like we'll repeat with either a co-testing or a LBC
Yeah.
or
Yeah.
yeah.
Correct.
And then again, if you are following only LBC, then again a repeat LBC after a year.
The
1
year.
year
Yeah.
later.
So once you have two negative, then you can
Then
go
you
for
go
your
switch for routine
yes.
screening.
I
Right.
think
And if
I
it
would like
comes
to
higher,
differ may
yes.
I would
Yeah.
just like to differ here a little bit, because now that we have this biopsy report that probably it is either CIN1 or CIN2, though the background is of ASCUS there, I would
You'd
think
like to
that probably we should keep her a little early for the follow-up. So say instead of traditional 1 year, maybe 6 months option can also be offered to her.
Lata, you
But
want to comment on this?
like the Colpo findings are low grade with the
It's okay.
biopsy
I
of
think it doesn't make much
6
of
month
a
to
this
6
thing.
month to 1 year is
So
and HPV is
that's okay.
negative.
Yeah.
HPV is
I mean,
negative.
Actually,
we are
it
not
was
HPV is
too
negative
negative.
only.
concerned.
Yeah.
We are not too concerned. So I guess 1 year is
Yeah.
Hmm.
fine. If
Yeah.
we have the same thing in 6 months, what are we going to do?
Yeah.
Yeah. We'll repeat after
Yeah.
6 months. Okay. So let's go to the next case.
So this is case 2, Mrs. Y, 50 years postmenopausal since 2 years. She came to us with complaint of burning micturition. She was treated for UTI, and then again a routine LBC was done. So we have Dr. Madhu here describe the LBC findings.
In this picture, you can see these are the blue colored cells, dark blue colored cells with the large nuclear cytoplasmic ratio. At this, you can see here these cells are the
Yes.
increased nuclear cytoplasmic ratio with the showing the hyperchromasia also, and with the nuclear abnormalities at this place. In this next smear, you can see these are the nucleus of these cells are showing the hyperchromasia, clumped chromatin, irregular nuclear chromatin. So, and these are the with the few normal superficial and intermediate cells are also seen. So because there is the mark to severe nuclear pleomorphism, hyperchromasia, irregular nuclear abnormalities. So this case signed out as a the HCL.
HCL.
Thank you,
Right.
ma'am. So what should be the next step in this case?
I will go for a colposcopy for her.
I know it's very straightforward, but the moment we have a report of HCL, we should straight away go for corpus.
Yes. So that's a message. So let's see the colposcopy findings.
So these are the colposcopy findings after normal saline and after green filter.
So we don't see any lesion, obviously.
Not on the saline and the green filter. Green filter and the type of TZ. Would you like to comment on that?
So it looks like that the transformation squamocolumnar junction has receded inside.
A little
So
bit,
we
yes.
cannot see the upper limit of the squamocolumnar junction here. So probably it's type 2 TZ or maybe even type 3, I should say. So probably looking at this kind of transformation zone, it's very important to take an endocervical sampling so that we know what is going on inside the endocervical canal. So we should try to make an effort
Yeah.
to see the endocervical canal as far as possible. And if not, at least try to take a sampling from that particular area.
So if one has an endocervical
Nisha,
speculum.
can I interrupt here, please? I'm
Yes,
Dr.
Dr.
Leela.
Leela. Yeah,
Yeah,
hi,
because
Dr.
I
Leela.
think we have not completed the colposcopic examination. We are only showing the normal saline and green filter.
Yeah,
There is no
we'll show
picture.
that.
Yeah,
Yes,
after that only we can comment about the transformation zone and what is to be done
Fine,
and all.
Dr. Leela.
Yeah,
Yeah.
they just wanted to Yeah,
No,
sorry.
no, no problem.
And for the comment on transformation zone, it is always better that to go for serial images. One
Yeah,
image,
yeah,
particular
yeah.
image does
See,
not gives a good
difficult.
interpretation.
Yes, yeah. That's
Yes.
what I just wanted to convey.
Yeah, absolutely. So even I was adding that only, that if you cannot see the upper limit of the transformation zone, then you should use an endocervical speculum or a simple non-tooth forceps just to kind of open it up and then see accordingly. That's what I was just adding at that time. So fine. So these are the 4 pictures that we have: the saline, and then the green filter, and acetic acid, and lugol satin. Whatever you can see, you can just comment. Obviously, from the just the 4 pictures, whatever you feel you can say, and then we'll just cover up the findings.
So we see here a lesion which is involving whole of the posterior lip of cervix as well as some part of the interior lip, though the upper margin of the interior lip cannot be seen. So what we see on the posterior lip here is a dense, thick acetovite area along
Yeah.
with some abnormal vasculature at maybe
Yes.
6 o'clock and 7 o'clock position.
Yeah.
And it's not taking up the stain even on Lugol's iodine. So it looks a high-grade lesion, and definitely a biopsy would be warranted here.
So we'll do the sweat score first, and then we will come to what should be, what are the options we can do, a biopsy or something more, whatever. So
So
scoring, you can show, Valina, just show the
So
scoring
it
for
is
this
a
case.
dense acetovite area with sharp margin, and we see abnormal vessels also. The lesion size, I won't be able to comment upon,
Yeah.
and there is distinct yellow appearance. So it
Yes.
definitely is a high-grade lesion with
Yes.
a score of approximately 9.
Yeah, so like you said, we must biopsy it. And Dipanvita, you want to say something else?
Yeah, so with this high-grade lesion with the background of HCl on pap smear, I would definitely like to go ahead. We can do the excision on the same sitting as well.
Yeah,
Like
so that
doing a
is just
LEDs.
an option. Yeah, so in such
Yeah,
cases when it is so
this
high,
histology is,
yes, so we
yes.
can do that also. That is the
Hmm.
see and treat, what we call that, if
So
on
because see the
colposcopy.
histology itself is showing CIN1, but my clinic,
Yeah,
our
cytology.
clinical,
Yeah.
clinico-cytological findings are not matching with the histology.
What is this? This is the biopsy report, Valina?
Yes, ma'am. This is the biopsy report which showed CIN1. But since
So
our clinical findings were not corroborating with the
Hmm.
biopsy report,
Hmm.
so we thought that we
So
should
what
take
could be the
another step
reason?
for it.
What could be the reason when this thing happens, that you got an HCl on the cytology and you did the colposcopy? It was a high score lesion. So what could be the reason?
Ma'am,
Some
it could be from not the representative side
yes.
from.
So sometimes a resident takes a biopsy not really from a a fainter area, because there may be parts of it where maybe it is a, so not a representative area. Sometimes it may be. So now what are you going to do?
I think I would like to add here that probably it
Yeah.
still could be an endocervical lesion as well. So we should also
Okay.
sample the endocervical area.
Correct.
It should not be
Okay.
forgotten.
Correct. Absolutely.
So in this case, lead was done for this patient further, and our final biopsy after that
So
showed
wait,
CIN.
Valina. So when you do a leap in such a case, what is, because Pratibha has put up that point. So what the importance of taking the top hat? I think you can just explain that. Pratibha. Okay. Pratibha, your mic is on. I think it's on. Dipanvita, would you like
Yeah,
to
so
just
if we are going
clarify
for
that?
the, if we are going for the LEDs procedure, definitely if the transformation zone is not visible, if it is type 3 or type 2, means you have to see the transformation zone type. So according to that, the type of excision will also differ. So whether it will be a type, it will be at least a type 2 excision or a type 3 excision. So where the whole is the chunk of tissue, the whole transformation zone with the big depth you have to take out, and have to also curate the do a endocervical curettage if it is type 3 transformation zone. So that depends on the TZ type which we are looking at colposcopy.
I think in this one they said that it was a type
Type 2
Two,
TZ, probably the
yeah,
upper border was visible. The whole lesion has to
after,
be
yes.
visible. If you are,
But the whole
in
thing
that case,
has
if
to
we
come
have
out.
any if we have any doubts, we can go ahead with the conization as well.
Right. So in
Depending
this,
on
a
the
leap was done, and with a top hat leap, so that the there is no chance of missing the endocervical
endocervical
upper
tissue.
limit, and then the histopathology showed cyan 2 in this case.
So
Let's move
margins are
ahead.
negative.
Yeah.
So
Yes.
comment on the margins are important here.
Yes, very important. That will help us decide the further course. So if margins are all negative, then we are done. She goes on an observation follow-up protocol. But so would you like to tell, if the margins are positive, then is it the ectocervical or the endocervical margins, the importance of either?
Yeah, so if it is means the endocervical margin, you can offer her, she is postmenopausal, right? So we have to do a re-excision probably. That's why
For the endocervical.
yeah, so cold knife conization
Right.
or
For the ectocervical, suppose the ectocervical margins are showing, the margin area is showing cyan 1 or something.
so it's not,
Can
it's
we?
follow up.
Yes, we can follow up. So that was another message we can give here. Okay, Valina, move ahead to the third case. I think we have that much time.
Yes, ma'am. So, moving on to case 3, Mrs. A, 42 years. She came to us with discharge for vaginum on and off since last 2 years, and she received kit 2 almost 2 to 3 months back, but she still has persistent discharge, and on examination, we found that the cervix was unhealthy. So we went and did an HPV test, which came out to be positive. So what should be the next step in this case?
Go ahead, colposcopy.
So we have the colposcopy findings after normal saline and green filter.
So these are the pictures you can just tell. So this one is normal saline, the first one.
The first
Second
one.
is the green filter.
So we can
And
see a
Yeah, it's again to start with, the colposcopy is adequate, squamocolumnar
Yeah.
junction is fully visible. So the
you can show the
transformation
next
zoom
two
type.
also.
Yeah.
Yeah.
So
Right.
it's like, yeah, the dense acetoate lesion with sharp borders, and this is called rich sign. So with raised epithelium, so it will be definitely a high grade lesion, if not invasive. So it will be like distinct, sharp, coarse, atypical, occupying all, and distinct
So
yellow.
all, yeah.
So we have to rule out invasive disease for her.
Yes. So yes, these are not the
So
cases where one should go for
thermal ablation.
thermal ablation, absolutely. So so if you do either you do a biopsy, or again, as we were talking, but only when the inner limit is seen clearly, then a leap. Otherwise, the endocervix is, then cone may be better. Otherwise, if you're not, yes.
So in this case, definitely I would like to rule out the invasive component.
Yes. So you do a biopsy.
Yeah.
So biopsy was done, and we have Dr. Madhu describe the biopsy findings.
The biopsy, the section shows this is the basal layer, and when we called as this is the CIN2 or 3, when the lower 1/3 plus the 2/3 area is involved by the atypical cells from the lower 1/3 and 2/3, but less than the entire thickness is not involved. Only the less than 2/3 area is involved by the atypical cells. You can see these some cells are showing the increased nucleocytoplasmic ratio and hyperchromasia, more hyperchromatic cells, and these are somewhere like this, some sitting like this, some like this. So these cells are showing the nuclear pleomorphism, hyperchromasia. These dark blue color cells are the hyperchromatic cells. So this involves the lower 1/3 of the area at this place, and at this place there is the only the 2/3 of the area is involved. 1/3 area is involved at this place, and at this place there is the 2/3 area is involved. So we write as a CIN2/CIN3, means this is the high grade dysplasia.
Okay, so treatment for this.
I think
This is a high grade lesion, clearly.
definitely it's a high grade lesion. Maybe we can straight away go for excisional procedures like LEAP or LEDs, or maybe even if one is comfortable, we can, because the lesion looked quite big. So we can even go for cone if required. So the lesion was big, pap smear or high grade lesion, HCL was there. And even though the biopsy is not showing it to be a high grade lesion, it's showing CIN1, but still in this particular case, I think
No, 2. It's showing 2 in this one.
CIN2. Okay, I missed it. So if it
2,
is
3. 2
CIN2
oblique 3.
becomes a high grade lesion, probably we should go ahead
Yes.
with a leap here.
So first message is not doing thermo and cryo in such cases. We have to excise these lesions. And leap or cone, cold cone.
I
or
would
a leap.
prefer a conization for her.
Yes. All right. What about, many people go ahead, CIN2, 3. What was the age of this patient, Valina?
Yes, ma'am.
I think 40s
Age.
probably.
40. So many people will just jump for a TH,
42 years, ma'am.
in these cases. So what is the disadvantage, or how can we, justify not doing that and first
42.
doing a cone and then going for it? I think that explanation to the audience is important. Any one of you can just talk about that.
So doing a conization would definitely, with this high grade lesion, I would definitely would like to rule out invasive disease.
Yes, yes.
So that is my sole objective. So if
Yeah,
it
that
is,
is the
if it is a if it's a high grade CIN3, her disease has been taken care of. If it is depends if it comes as
invasive.
a malignancy. Yeah, if it comes as a malignancy, I can look for the invasive component, how much invasive it is, how much is the stromal invasion, the LVSI status of that, whether I have to, because it will help me to further
Plan the surgery.
plan her course of management.
Yeah.
So I will never do a THBSO for her. I will definitely do a conization. And
Yeah.
then if it comes as positive for malignancy, I would look for the LVSI status, that whether I have to address her lymph nodes or not.
Yeah. So
That
I
would
think
be
that
my
is the
approach.
important thing. It many times gynects feel that let's do it. It's her age, postmenopausal, or say. So important thing is that if it is invasive, you have done incomplete surgery, and that is what we do not want to do. So although it will be a two-step, doing the cone and then doing it, but if the cone margins are free and all, then you have done. It's over
The
also.
job is done.
Yes.
Yeah. And
Yes.
and if in with this clinical picture, with this colposcopy of high grade but biopsy is not corroborating, we can
Yes.
review the slides again.
Yes. Okay.
So we can go to our pathologist and request them to review the slide and the history, writing the history on the biopsy form is so very important.
Yeah.
So this will guide us to to plan the further course.
So I think, Valina, this was the case where there was microinvasive this thing that came out. Somebody had done this THBSO. You have written CIN2 only.
Oh, yes, ma'am.
I think,
Because
yeah, you just made that.
Yes.
Yes, it was a microinvasive. That's why we had actually taken up this case, because somebody, yeah. So that is what we were just discussing, that just to not to miss an invasive one in such cases, we must first do a cone, and then depending upon the results, we should take the final decision. So next, please. So and full follow-up protocol, even if a hysterectomy has been done with a CIN2 or 3, I mean, any of the pre-invasive lesions, what should that be? So still we need to follow up as a
As a HPV testing.
yes,
Do with the
yes.
HPV
So it
testing.
has to continue. So the point is that
Yeah.
by doing that is another thing, that by doing hysterectomy doesn't mean that you just leave her alone, and you have to still do the surveillance. So anyways, that is another reason that you don't finish it up there. You have to monitor her. So that was the message we wanted to give through this case. So that is it. I think we have covered all our 3 cases well in time. If there is anything more anybody wants to, we can see some questions in the chat, or maybe before that, if Dipanvita or Pratibha, you want to add on any points here related to colposcopy and management of pre-invasive lesions.
Just one thing, whether we are looking at ASCUS or LCIL or HSIL, whatever management, either colposcopy or an excisional or an coagulative procedures we have, ablative procedures we have planned, it's equally important to stress upon that all these women will require follow-up.
Yes.
And that must be stressed upon. It is not that once we have done the excision and the procedure is over. These women
Yes.
will require follow-up, and that needs to be stressed upon. I think that's the only thing which I would like to add.
Yeah. And it will be a closer follow-up, not like the
Closer
routine surveillance. Yes.
Yeah.
And
Dipanvita, you
regarding
want-
the colposcopy, doing and practicing colposcopy, because most of the postgraduate student does not practice it during as a routine in their post-graduation period. So it is, when you start doing colposcopy, don't miss the steps. You do step in a stepwise fashion, make it a practice. So over the years, you will learn the art of colposcopy and the interpretation of findings, so that we don't miss the actual interpretation or whatever the finding is, and which guides us to reach to a conclusive diagnosis as well as plan the course of action. So
Yes.
whatever we are doing it as a routine practice maybe, but doing it routine, make it a practice to do not, so that you will not miss a step.
Miss the
If you
points.
follow,
Yes.
yeah. So if you do FCPC colpo terminology, apply colpo terminology for all the colposcopies, maybe 1 or 2 you are doing in a week, but you take a printout, make a point that you are ticking all the points, and then doing sweat score. We do have modified sweat colposcopy index now, which was published in 2019, where the size of the lesion and Lugol staining has been removed for the colposcopies trainees, to make it more simplified. So that's
Yeah.
how you will reach to perfection. It's for the postgraduates,
Yeah,
or
very
the
rightly
DRN,
said,
DRCS
because
students.
yeah, people don't spend time on that colposcopy, they just try to hush it up. So in this chat box, I think Dr. Priyanka Shahi had asked, lesion is going inside, is it? Yeah, it was on the first look without this thing, any endocervical speculum or this thing, it was looking like going, but when it was opened up, we could see the upper limit. That's why we labeled it as 2. So that's the answer to you. And then Dr. Rakhi Rai has said, patient with HPV 16-18 positive on routine screening, LBC NILM, no TZ seen. On colposcopy type 3 TZ, no lesion seen. ECC done, no abnormality. What should be the next line of management? So so she is HPV positive, basically LBC negative, and colposcopy, no lesion seen, ECC also normal. 42-year-old. Would anybody like to
I think
suggest?
WHO recommends that doing 16-18 positive with a type 3 TZ, you have to address the transformation zone. So doing a small loop, the type 1 excision of transformation zone.
So yeah, I'm surprised, like they have done ECC, which is normal, but nothing, no biopsy or anything from the
Yeah, no, the
ectocervix.
random biopsy, Dr. Rakhi has mentioned that random
Written?
biopsy was shown. Yeah, shown CIN1.
Where I can't. Acha, it's
Abhinav,
later. Okay, now she has put up. So random cervical biopsy is CN1.
So that this also depends that what was the window period of this colpo finding, the HPV report, when the HPV, the gap between the HPV testing and the colpo and the biopsy. If it has, so I don't know, it's like if it has been done within a month or so in a quick succession,
It's okay.
so I would look. I would
So the
definitely, it's
gap,
a type 1
yeah,
excision.
gap should not, yeah, she's written immediately. Thermal ablation, also an option.
Why
for
not
these
follow up
cases.
then?
Yeah, it should be
Exactly.
follow-up actually.
If histopathology is because we have to follow histopathology. Histopathology is gold
Yeah,
standard.
that's okay. So if it is
CIN1,
CIN1, then it
ACC
is fine.
negative,
Yes.
Colpo normal. Even if
Then
it
you
is
can do.
HPV 16-18 positive, we can follow her
Yes.
up after a year with the HPV
We can
testing
follow
again.
also. Yes, we can do
Follow
also. But if nothing comes, then follow-up is important with that HPV positive. You know, if rest were all normal at this point of time, then a repeat one to see that it is going off also is important.
Yeah.
Okay.
And I think
So
Dr. Dimpy's question has also been addressed, right?
that I think
Yeah,
Dr.
we have
Lata-
addressed that question.
Yes.
In our first one.
So Lata, I think if there's nothing more, should we?
Yes, I think so. I think, wonderful colposcopy pictures, very crisp pictures, and very nice presentations, emphasizing on basic points of colposcopy. And I would like to add to Dr. Dipanvita's comment about, the routine of colposcopy, and the Colposcopy Atlas, which is on the IARC website, is a wonderful resource. It has excellent pictures, which I think all postgraduates will benefit from going through the Atlas as well. So I would like to thank all of you. Thank Dr. Nisha and her team for and the panelists for a
And the
wonderful
experts.
discussion. Yes. And all the people who have joined it. I think we were at about 78
Yes,
participants.
it
So
reached.
that is very heartening to see.
Quite a number.
Yes,
Quite a
and
number,
I'll
yes.
request everybody to put on the videos. At least we'll have one picture at the end of the program.
Yeah, I think we can put our videos on. I'm not going to put my video on because, I'm traveling in the dark, but we can definitely take a picture. So if you can request
Yes.
everyone to put your videos on.
Yeah.
I wanted to emphasize Dr. Lata's
Yes,
point.
repeat.
IARC
Yeah.
colposcopy on website, it is freely available. It is really good.
Yes, yes.
You
Dr.
just have
Madhu
to
also, please show up.
Yeah, you just have to put up IARC colposcopy atlas, so it comes up.
Yes. So
And I
lot
think
more.
Dr. Helen Kamei is doing the next Colposcopy MDT next March. So if any
Helen
one
is
of
here.
you would like to, if any one of you would like to moderate the next colposcopy session, please let me know, because we want the MDT to travel all through India, basically. So, everybody gets a chance, and,
Yes.
we get to see the practice that comes in from all across India, and all of us learn from each other as well. So if anybody is interested in moderating, please let me know, and we will accommodate you in the academic calendar. So Dipanvita, do you want to say a few words about what we have planned as part of the AOG in India academic calendar?
Yeah, so as a part of the executive committee member, so we have planned quite multiple events. So the next is that Colpo MDT, which we do host for every month, last Friday throughout the year. Then in in May 10, we are hosting the AOG in India interim CME, interim meeting, which will be in Kolkata only, 10th May. So feel free to join. I will soon be receiving the flyers and all. Then in August, we have the AOG in India National Conference. Sorry, I forgot to mention on March 11, the Orissa team is conducting a HPV preventive oncology workshop at AHRCC, Cuttack. And in June, we are hosting a webinar in association with ASGO, Asian Society of Gynae-Oncologists, the ASGO AOG in India collaboration. The webinar would be on preventive oncology. Then multiple hands-on training workshops we are planning for the postgraduates throughout the year across the nation, with a dedicated focused workshop on molecular oncology will be done by Dr. Vijaya Ramshankar. These are the right now I can remember all these
We'll be
academic
planning one.
activities.
Yeah.
Yeah, Dr. Nisha,
So,
you are planning in
July.
July. There will be one in Ames, Delhi. There will be one in November or December, maybe November or January. Then one from the UCMS team. Lots of laboratory workshops. So this year, Eugene India is mainly focusing, apart from these webinars and this academic CMEs, we are planning to do part by part hands-on training for the postgraduates and the TRNB students or MCA students. So that is a part of our agenda for this current year.
So
thank you so much.
requesting everyone to join in into their, wherever the meetings are held, we'll be having it all across the country. So requesting all the participants to join wherever it is convenient for them. We will keep you posted on the annual meeting, AOGEN India meeting that's being hosted by Dr. Ranu and her team. That's in August. So please block
That's
your
in
dates.
Jaipur.
In Jaipur, yes. So that'll be a wonderful meeting and it'll be good to meet everyone. So thank you all very much for joining in and have a very good evening. Bye. We'll see you next month for the next Colposcopy MDT. Bye-bye.
Thank you.
Bye-bye.
Bye.
Thank you.
Bye. Thank you. Bye.